very good afternoon to all. Thank you, AI Scientific Committee, for giving me the opportunity to talk on the topic of ABCD of glaucoma diagnosis, in which we will be discussing a step-by-step guide for mastering the art of glaucoma diagnosis. So yes, we start with the A, which is a thorough history exam, then a slit lamp by microscopy, correct IFP measurement, detailed gonioscopy, evaluation of optic nerve head. Thank you to madam, we have almost covered the topic, and fields and relevant investigations. So what is the importance of history? It is the first step of doctor-patient interaction, and it's the aim to win the confidence of the patient, and we will develop a rapport. So we should know about the patient's age, the ethnicity, the location where it comes from. Then we have to ask the duration and severity, and what are the symptoms of blurred vision, eye pain, colored halos, field of vision. But yes, we cannot forget the fact that primary open angle glaucoma is a silent thief of vision. Ask the past ocular history of what is the refractive correction of the patient, whether he had any trauma, any laser procedures were done, any surgery was done. Along with that, we have to ask if the patient is using a chronic, like long-term steroid use, or any known documented allergies there. Systemic features, which can cause glaucoma, and we have to ask. Some patients' lifestyle changes, like some people have a habit of having a lot of water in the early morning, and some yoga posture like Sirsasanas have known to cause raised IOP. Along with that, we have to ask about the socioeconomic history of the patient. Some occupations like trumpet blowers are known to have increased IOP. Along with that, family history of glaucoma has caused a 10% increased risk of glaucoma. And here we have done a study in our institute which shows 6 generations of patients having juvenile open angle glaucoma, and documented mutation in N480 mutation. Examination should start with general examination, and systemic and ocular correlation has to be done. Like here you can see a child with phacomatous pigmenta vascularis, another with neurofibromatosis. Going on to facial examination, in Indian population, we can easily miss this port wine stain on a sturgeon patient. Along with that, oculomelanosis nevi can also be missed. So a detailed slit lamp examination should be done. Along with that, we have to find the clues for a raised glaucoma, like dilated episcleral vessels, Harb's or post-vitreoretinal surgery, or other signs of post-surgeries has to be documented. Van Harris grading is important, but yes, don't miss gonioscopy. Gonioscopy is must. Glaucoma screening, yes, a simple torchlight test that can give a clue of glaucoma, even if you are campsite or peripheries, is a RAPD, which has to be done. Look for ultimately for the signs of AGM allergy. Look, and then starts with the tonometry. As you know, there are many tonometers, different classification. You should know tonometer, but yes, we have to go ahead with applanation tonometer. So here I'll start discussing the steps for measuring the using applanation tonometer. Ensure the weekly calibration has been done. It should be done by you. Make sure you're not asking your technician to do it, because high chance of missing the readings. Explain the procedure to the patient, because patient may have anxiety and may squeeze the eye. Sterilize the tip before and after the procedure. Then complete the setup, bring the tension knob to 1. Don't make it at 0, because that will cause abrasion and because of hysteresis. Then use the cobalt filter, enlarge the full, dim the room lights, and go ahead. Make sure you have approximately 60 degrees between the microscope and the illumination source. The end point is the meeting of the inner semicircles, and multiply by 10. That will give you the reading. But yes, be well aware of the factors which can overestimate or underestimate your changes, like thick cornea, thin corneas, astigmatism, and accordingly we have to modify. Then coming on to gonioscopy, it is very essential for guide of diagnosis, formulate a treatment plan, and planning ahead for intraoperative images. So you should know the gonio lens which you are having and what you are going to see, whether you're using a Goldman, Zeiss type, and the importance and benefits of, and the case by selection for it. Check for the surface of the gonio lens every day, I must say. Explain the patient procedure, make him comfortable, put adequate topical anesthesia, practice correct placement of the lens, ask the patient to look up, gently place the lens, and go ahead. First look at the superior, then the inferior, then turn around 90 degrees, then you can use in the lateral side. Practice placement of the lens very gently. You have to place to avoid any corneal folds. Then centration has to be checked. It should be in primary position, and a good way to look for any decentration is the appearance of an air bubble that proves that the area, that portion the lens had decentered. Then along with that, make the external wedge, then accordingly grade your angles, and describe the angle structures which you are seeing. Then describe according to whatever grading system you're using, a clear indication of how open the angle should be there in primary position. Insertion, iris insertion and angulation, the amount of pigmentation, any peripheral anti-cyanicae, neovascularization, and other structures. Then ONH evaluation, we go ahead with a 7-step, as madam described, from size, then shape, then cup disc or the rim disc ratio, then the rim shape, any notching is there or not, RNFLD, whether it's a localized or diffuse, disc hemorrhages, and any peripheral atrophy. Then order relevant investigation. What I believe the must investigations are pachymetry, HFA, OCT, GCC, RNFL, and fundus photo. And not at all, not limiting to that, we have to do a progression analysis of all these three to clearly cut what we are dealing with. And then we can do a case-based analysis of ASOCT or UBM. Pachymetry plays a very important role. Then we have to know what is the central corneal thickness we are dealing with. As you can see, the percentage changes, percentage of propensity of having a glaucoma in an ocular hypertension patient can be high, can be changed according to how thick how thin the cornea is. And these are some scales present to correct it. Always correlate your investigational findings from what you have seen in the examination. So here is my ABCD of the glaucoma examination. A proper systemic and ocular history taking and stepwise examination give utmost importance to tonometry, and gonoscopy is the key to glaucoma diagnosis. To summarize, eventually all the pieces should fall in the place. I'm always thankful to the place where I learned ABCD of my glaucoma. Thank you all for patient listeners. Welcome to my hometown for your year's midterm. Thank you.
Thank you. Thank you, Dr. Shivam, for wonderfully explaining all the basic points and the multiple factors which helps us to make the diagnosis of glaucoma. Very nice.